Hi guys, so apologies, my eyes look really puffy today, but and I'm a bit late for today's lesson. I'm recording this one by the way, so I have muted everyone. So last lesson we discussed about the peripheral vascular system. So we talked about the anatomy of the arteries, the veins, and the capillaries, and we talked about transcapillary exchange, so the exchange of substances in the capillaries, and we mentioned the hydrostatic pressure, which is the pressure pushing out, and the colloid osmotic pressure, which is the pressure that's trying to bring stuff back into the capillaries. I think we also spoke about the lymphatic system, including the lymph vessels and some of the lymphoid organs like the lymph nodes. And I think that's about it. So I actually didn't discuss the most common concerning symptoms. So I'll do that in a separate video. For today's video, I want to focus on talking about techniques of examination. So how do we actually examine the peripheral vascular system? To do a peripheral vascular examination, we need to assess the carotids, and then we need to assess the arteries in the arms, and then we need to assess the great vessels in the abdomen, and then the arteries and the veins in our legs. So we start with assessing the carotids. So our patient should be sitting upright on an examination bed. So starting with the carotid. So firstly, we need to palpate the carotid. We need to locate it. So it's in the inside medial border of the sternocleidomastoid. We palpate that. We don't palpate both carotids at the same time because, like I said last time, this is gonna cause decreased blood flow to the brain and may induce syncope. For carotid assessment, we need to assess the pulse rate. We need to check that that's normal. We need to assess the amplitude of the pulse and the contour of the pulse. So the contour involves the speed of the upstroke, the duration of the summit, and the speed of the downstroke. So the upstroke is usually brisk, the summit is usually smooth and rounded, and the downstroke is less abrupt than the upstroke. After the palpation of the carotids, we need to auscultate both of the carotid arteries on both sides for any bruits. So we use the bell of our stethoscope to do this. Now moving on to the arms. So firstly, we need to start with inspection. So we inspect from the fingertips all the way up to the patient's shoulders. So we look for things like the color. Is there any paleness? Is there any cyanosis? Any signs of amputations? Any bruises? Any ecchymosis? Any ulcers? And we need to assess the temperature as well. We need to compare the temperature on both sides. So we just feel the temperature from the hand to the forearm up to the patient's shoulder, and we do that on the other side. Well, we do it simultaneously, but I can't do it to myself simultaneously. So you do that, and you just compare the temperature between the two sides. And there shouldn't be any massive discrepancy in temperature. And then after that, we move on to assessing the capillary refill time, or the cap refill time. So what you do is you just press on the nail bed. So you see that's the nail bed. You just compress until it turns white. So now it's white. And then you release and you record the time it takes for it to regain its color. So mine took about like a second there. Right. So the normal cap refill time is under 3 seconds. So anything longer is abnormal. And then we move on to actually palpating some of the arteries in the arms. So we start with the radial artery. So we note the character, the amplitude, the rate, the contour of the pulse, and we compare both sides. We see if there's any radial delay, which may indicate coarctation of the aorta if that delay is present. And then we can also palpate the ulnar artery and the brachial artery. So if indicated, we can also measure the blood pressure in the right and in the left arm, and we can compare the blood pressures between the two arms. And normally, the difference should be less than 10 millimeters of mercury. Anything greater is abnormal, and it indicates that there is narrowing of the arteries on the side with the higher blood pressure. After assessing the carotid pulse and the arteries in the arms, we now move on to assessing the aorta in the abdomen. So we need to lay our patient supine because, as you remember, the patient was sitting upright on the examination bed when we were doing the carotid assessment and the assessment of arterial pulses in the arms. So we need to lay the patient flat, supine. You can elevate the head of the bed if the patient has any difficulties with breathing. So we need to expose the abdomen, and we need to feel for the aortic pulse. So we need to estimate the width of the pulse. So estimate the diameter of the abdominal aorta between our two fingers, and it should be less than 3 centimeters in diameter or in width. So we do this especially for our for our older patients who are smokers, because they are at a higher risk of abdominal aortic aneurysm. And then after estimating the size, the width or the diameter of the aorta, we move on to palpating the superficial inguinal lymph nodes. So recall that the superficial inguinal lymph nodes, we have two groups. We have to palpate for the horizontal group and the vertical group. So the horizontal group, they lie in a chain in the anterior thigh, just below the inguinal ligament. And the vertical group, they lie also in a chain near the upper part of the saphenous vein. So when we're palpating for these superficial inguinal lymph nodes, we need to note down their size, their consistency, and if there's any tenderness in those lymph nodes. And then after assessing the lymph nodes, we need to auscultate. We need to move on to auscultation and auscultate the great arteries in the abdomen. So we need to auscultate the aorta, which is in the epigastrium, the bilateral renal arteries, the bilateral iliac arteries, and the bilateral femoral arteries. And we need to listen for any bruits. Moving on to the assessment of the arteries and the veins of the legs, we first need to start with inspection. So we inspect from the groin to the buttocks all the way up to the feet and the toenails. So we look for things like the size and the symmetry of the legs. We note any swelling or any edema. We look for any venous enlargement in the leg. We look for any discoloration or abnormal pigmentation. So if there's brownish discoloration around or above the malleolus, that is indicative of chronic venous insufficiency. We also need to check for any ulcers in the leg and the back side of the leg. So we lift the patient's leg up to check the calf area if there are any ulcers there. Also in between the toes, we need to check if there are any ulcers in there. And we need to be able to determine or distinguish the ulcers caused by chronic peripheral arterial insufficiency versus the ulcers caused by chronic venous insufficiency. And I will talk about this in the later part of this video. So after inspecting for any ulcers, any pigmentation and discoloration, we can check for the temperature. So again, we feel if there's any difference in the temperature between the two legs. So we start from the feet, move up to the shin, to the thigh, and up to the groin. We just assess the temperature using the back side of our hands. We also need to pay attention to the distribution of hair and if there's any hair loss. And finally, we need to inspect the saphenous system and check for any varicosities. After the inspection of the leg, we need to move on to the palpation. So if we noted any varicosities in the saphenous system, we need to check for those varicosities. We need to palpate them. So what we do is we ask the patient to stand up, because in that way the superficial veins would fill with more blood due to gravity, and we can palpate these and check for tenderness and check for thrombophlebitis, or the inflammation of these vessels. And after that, if we noted any swelling or edema, we need to palpate for pitting edema. So we do this by using our thumb, applying gentle but firm pressure on 3 key areas. So we press on the dorsum of the foot, we press on the medial malleolus, so behind the medial malleolus, and then we press on the shin. Okay, so again, those 3 key areas: the dorsum of the foot, behind the medial malleolus or the ankle, and on the shin. A positive test for pitting edema would mean that after pressing those 3 key areas, our thumb would leave like a dent or depression due to the pressure that we applied. So after we palpate for pitting edema, we need to kind of establish if the edema that we're seeing is unilateral or bilateral. So bilateral means both sides, unilateral means one leg looks swollen and the other looks normal, or the one leg looks bigger than the other. So if there is unilateral edema or swelling, we need to measure the circumference of the cuff. Okay, so we measure the circumference of the cuff just 10 cm below the tibial tuberosity. So usually, so we measure the circumference in both cuffs, 10 cm below the tibial tuberosity. So normal would be less than 3 cm in difference between the two cuffs. If the cuff asymmetry is greater than 3 centimeters, then we need to suspect DVT. So other causes of unilateral cuff asymmetry or unilateral swelling of the ankle and the cuff includes venous, like chronic venous insufficiency, DVT as I mentioned is one, and lymphedema and incompetent valves in the saphenous system. Also, there are less sinister causes of the cuff asymmetry, so we don't, but we need to rule out those ones that are quite severe and life-threatening, especially DVT. So the cuff asymmetry may also be caused by muscular tear or muscular trauma or muscular atrophy. If we see bilateral swelling or edema of the cuff, the legs, and the ankle, then this can be due to heart failure, nephrotic syndrome, and liver cirrhosis. So after palpating for the varicosities and palpating for pitting edema, checking if pitting edema is present, and measuring the cuff size if there's unilateral swelling, we need to measure the cap refill time in the toenails, similar to how we did it on the fingernails. And again, the normal would be less than 3 seconds for the return in color. After that, we need to assess for the temperature of the legs. So we start from the feet, moving up to the shin, to the thigh, and to the groin. So we just compare the temperature between the two legs. So hopefully there isn't like a massive discrepancy between the two, and hopefully the legs are not cold, because that would indicate arterial insufficiency. After all of that, we need to move on to palpating the individual arteries of the legs. So we start with the femoral arteries. So the femoral arteries, we need to palpate deeply, just below the inguinal ligament, midway between the anterior superior iliac spine and the pubic symphysis. So sometimes we may need to use both hands, so one hand on top of the other, to palpate for the femoral pulse in case our patient is obese, for example. And absent femoral pulse, we need to suspect peripheral artery disease or arterial insufficiency. And usually if the occlusion occurs at the aortic or the iliac level, all the pulses distal to that will be affected. And if we feel an exaggerated widened femoral pulse, then this might indicate a dilatation of a femoral aneurysm. After palpating the femoral artery, we need to move on to palpating the popliteal artery. So to do this, the knee should be somewhat flexed with the leg relaxed, and we need to place, wish I could show you what I'm doing. We need to place our fingertips kind of in the midline behind the knee, and we press deeply into the popliteal fossa. So the popliteal pulse may be difficult to find. It's actually a lot harder than the other arterial pulses, because the popliteal artery lies very deep and the pulse feels a bit more diffused. If you can't feel it in this approach, what you can do is to ask the patient to lie in a prone position, so they're facing down, and you need to flex the knee around about 90 degrees and rest their lower leg on your shoulder, and you have to press deeply with 2 thumbs, again behind the knee in the midline, into the popliteal fossa and try feel for the popliteal pulse. Just try your best. It's there, I promise you. And if we feel an exaggerated widened pulse in the popliteal artery, then that might be indicative of a popliteal artery aneurysm. After palpating the popliteal pulse, we need to move on to the Dorsalis Pedis. So this would be easier if I could show you my foot, but I don't want to show you my foot. So I'm just going to describe the location. So it's like you need to palpate the dorsum of the foot, so the side of the foot, and it's kind of like medial. It's kind of like in the middle, just above the ankle. But this pulse may be congenitally absent, or the artery can branch higher, like much higher up in the ankle, so you might have to readjust your two fingers to feel for the Dorsalis Pedis pulse. The next one is the posterior tibial artery. So to feel for this pulse, you need to use two fingers, or you could even curve your fingers. And you need to feel at the, so behind the medial malleolus, slightly below it, but definitely behind it. And just feel for the pulse, the posterior tibial pulse there. Acute arterial occlusion from embolism or thrombosis will cause pain, tingling, and even numbness of the limb distal and below to that occlusion. And this will result to the limb feeling cold, looking pale, and even feeling pulseless. So we need to assess for the temperature of the limbs. I think I already mentioned this, but if you get bilateral coldness, then that could just be because of the cold environment. But if you get unilateral coldness, then we need to suspect arterial insufficiency, or a PAD, peripheral artery disease. And you need to suspect that on the limb that feels cold. We have a couple of special tests that we can do to further assess the peripheral vascular system. And these include the Allen test, the Buerger's test, the TAP test to map out the varicose veins. We have the Trendelenburg test, and we can also measure the brachial, the ankle brachial index, or the ABI. The first special test that we can do is the Allen test. So the Allen test is used to assess the arterial perfusion in our hand. So this is also used to compare the patency of the radial artery and the ulnar artery. And we can use this to assess the patency and to ensure that the ulnar artery is patent before we do any procedure to a radial artery. So for instance, if you want to take an arterial blood gas from the radial artery, we need to check that the ulnar artery is patent before we do so. To do this test, what we need to do is we need to ask the patient to make a tight fist, and we need to compress both the radial and the ulnar artery. We need to compress them with our thumbs. So obviously I can't do that because my other thumb is there, but let's imagine that I'm compressing the radial and the ulnar with both of my thumbs. And you need to ask the patient to open their hand, and it should look pale. Well, obviously because I'm not compressing these, it just reperfused. But what you should have seen, so you ask the patient to make a tight fist, you compress the radial and the ulnar with both of your thumbs. I'm just gonna do this so you see what you should actually say. So you ask them to open their hand, and it should look pale like this. And you need to release just the ulnar artery and keep compressing the radial artery, and this is what you should have seen. See, that flushing or that reperfusion is what you should have seen when you release just the ulnar and still compress the radial. That's if the ulnar artery is patent. Persisting pallor or persisting paleness of the hand after the release of the ulnar artery suggests that there is an occlusion in the ulnar artery. The next special test is called the Buerger's test. So this test tests the arterial sufficiency in the legs. So what you need to do is you need to ask the patient to lie in a supine position, and you need to elevate their legs from about 45 to 90 degrees. depending on the patient's mobility, for about 2 minutes. And then you need to look for the limb to become pale due to the emptying of the superficial veins. So marked pallor suggests arterial insufficiency, because this suggests that the leg, the arterial pressure is unable to pump the blood through the arteries in the leg against gravity. And what you need to do after this is you need to ask the patient to sit on the examination bed with their feet kind of dangling down, just hanging down. And what should happen is that now gravity should aid reperfusion. And what you need to see is the return of the pinkish color of the skin within under 10 seconds. And if you also need to look out for reactive hyperemia. So reactive hyperemia is characterized by the initial loss of pallor when the patient puts their leg down, hangs their leg down, but this is then followed by the spreading redness in the leg area. So reactive hyperemia or reactive rubor is a sign of arterial insufficiency. The next special technique is about mapping out the varicose veins. This is called the tap test, I think. So what you do is you obviously locate the vein, and then you put your palpating finger on the top, and then you put another finger on the vein just below the top palpating finger. And what you do is you tap the vein on the lower finger, and you should feel a pressure wave transmitted to the upper finger. If there's that palpable wave transmission, then that means that the two parts of those vein are actually connected. The fourth test that we can do is called the Trendelenburg test. So this test assesses the valves of the saphenous system. So what you need to do is to ask the patient to lie supine, elevate their leg to about 45-90 degrees, again depending on their mobility, until it empties with venous blood. And then what we need to do is to occlude the great saphenous vein by placing like a tourniquet around the upper thigh just below the sapheno-femoral junction. And during occlusion, the rapid filling of the superficial veins during occlusion indicates incompetent valves in the communicating veins, because that shows that there is retrograde flow of blood from the communicating veins in the deep system to the saphenous system. And then what we need to do is we need to ask the patient to stand up while still keeping the tourniquet in place, so still occluding the great saphenous vein. So when they stand up, what we need to look for is the filling of the saphenous vein. And usually the filling of the saphenous vein starts from below the occlusion, when the capillaries the capillary bed empty their blood back into the venous system. After the patient has been standing for about 20 seconds, we release the tourniquet, we release the occlusion, and we look for the filling of the saphenous vein. So normally what we should see is the the continuous slow filling of the saphenous vein as the valves in the saphenous system should prevent retrograde backflow of the blood. But if we see rapid filling of the superficial veins, then that indicates that the valves in the saphenous system are incompetent, because the blood, they're backflowing into the superficial veins. Sorry guys, I had to change phones because my other one just died. So I think I was talking about the last special test that we can do. So we can measure the ankle brachial index. So this is just a test to measure the severity of the PAD, or the arterial insufficiency. So what we need to do is we need to ask the patient to lie supine, and we need to wrap the blood pressure cuff around the right arm over the brachial artery. So we need to put ultrasound gel over the brachial artery and use a Doppler to help us locate where the brachial artery is. And then we inflate the cuff around about 20 millimeters of mercury above the last audible pulse. So when we hear the pulse disappear, we just inflate it, well, just add like 20 millimeters of mercury pressure onto the cuff. And then after that, we release this slowly and we record the like the pressure where we hear the pulse again. Okay, so we repeat that on the left side as well, and we try to take like at least 2 measurements so we could get like an average. Okay, and then after that, to measure the blood pressure on the leg, what we need to do is we need to wrap the I don't know what I was gonna show you. I was gonna show you my ankle. So we need to wrap the blood pressure cuff kind of around the ankle, so above the malleolus, and then we need to put ultrasound gel over the Dorsalis Pedis, and we need to locate this with the Doppler, and then we listen via the Doppler for the pulsation, so the sounds, and we inflate the cuff up to 20 millimeters of mercury from the last like audible pulse, and then we deflate this slowly, and then we record the pressure where we hear the pulse again, and then we repeat that for the posterior tibial artery, and then also we repeat that on the left leg. Okay. So you basically do it on both sides, both arms and both legs. You do it over the brachial, you do it over the dorsalis Dorsalis Pedis, sorry, and the posterior tibial artery. Actually calculate the ABI, or the ankle brachial index. We actually need to do it on the right side and the left side. So to calculate the right ABI, what we need to do is we need to divide the highest average pressure from the right side leg reading, so either the Dorsalis Pedis or the posterior tibial readings. Divide that by actually you could use either arm or both, whichever one would give you the highest average. Okay, so just to summarize, for right ABI, you divide the highest average right leg readings, divide that by either or both of the arm readings. And for the left ABI, you just use the left side leg readings, the highest average from the left side leg readings, either the Dorsalis Pedis or the posterior tibial. Divide that by either the right, sorry, this is the left, the left arm or the right arm readings. Or you could use both, whichever one's going to give you the highest average reading. So once you've entered those numbers in those equations, you can now calculate the ABI, or the ratio. So if you get a number that is higher than 0.9, then this is a normal reading. Okay, so it's normal. There's no arterial insufficiency. If the ratio is between 0.8 to, 0.89 to 0.6, then this suggests a mild arterial insufficiency, a mild PAD. If the reading is between 0.59 to 0.4, then this is a moderate PAD. If the reading is below 0.39, then this is a severe PAD.